Okay, that is the best introduction I've had, Steve. I will carry that with me. So I'd like to thank Dr. Guthrie for the invitation, to Dr. Soprano, to all of you for having me. It's really lovely to come to a place where there are friends and colleagues. And you can't scare me with the snow, because I come from Toronto. What I'm going to talk about today is something that's a relatively new focus in pediatrics. I'm going to focus a lot of what I talk about on liver disease, because I am a hepatologist, but I hope that as I talk, that you will think that the concepts that I'm discussing are actually relevant to many aspects of chronic disease in pediatrics. So I think that this has been a relatively untouched field by our community yet to date, and it's something that we need to address. Okay, here we go. These are my disclosures, but I'm not going to be discussing any of these drugs today. And the objectives for today are to understand the concept of frailty and its relevance to children. I will talk about a lot of the data that's mostly in adults and some in pediatrics about frailty in children with liver disease, and then also to explore sarcopenia, which is considered the biologic correlate of frailty. So what is frailty? It's really a concept that we've borrowed from geriatrics or gerontology, and it's a domain of patient risk. And it was defined by Fried in the early 2000s thus. So it's a biologic syndrome of decreased reserve and resistance to stressors resulting from cumulative declines across multiple physiologic systems and causing vulnerability to adverse outcomes. So when you read that, I think you can instantly see how that is applicable to our children with chronic disease. Sure, they may be talking about the elderly, but the elderly are at one stage of physiologic decline, but our children are also vulnerable in a very similar way. So just from a conceptual basis, I think that this is very easily applicable to children with chronic disease. And it's a clinical phenotype, and you can, if you look at the figure there, you can consider it as sort of a mutually exacerbating cycle of negative energy balance, malnutrition, sarcopenia, muscle loss, leading to low physical activity, and all of this just really working in a cycle that exacerbates each other. And it can be, Fried originally described frailty as being divided into 5 categories or 5 domains, which they described as weakness, slowness, exhaustion, shrinkage, and diminished physical activity. And more than just a concept, you can actually measure it. So it can be measured in a very reliable and reproducible way in adults. And there are multiple metrics for measuring frailty, but these are the Fried frailty criteria. And usually, these are really the ones that have been most used in a research setting. And so weakness is measured by grip strength. Slowness is measured by the 6-minute walk distance. I'll describe that later. Exhaustion in adults is measured by a self-report it's a questionnaire-based study of exhaustion. Shrinkage is measured by self-report of unintentional weight loss. It's have you lost more than 10 pounds in the last year. And diminished physical activity is also measured by self-report, looking at activity and how many calories you may expend in a week. And the way that this is scored in adults is that if you are weak, if your grip strength is low according to validated norms, you can be scored a 0 or a 1, and you get a maximum score of 5, and then you're frail if you have a score of 5, of greater than 3, and if you're 1 to 2, you're considered pre-frail. This has been studied and used in multiple adult populations. And it has clear consequences. It's not just a description of a phenotype, it actually means something. So a high frailty score in the elderly is associated with increased hospital admissions, increased falls, decreased independent living, and then most importantly, I would say decreased 3- and 7-year survival. So clearly it's not just a description. I mean, it's prevalent. You can see here in a study, in a European study, it's prevalent in 17% of older community dwellers. So not only is it a quantitative description of a phenotype, it also has adverse outcomes associated with it. It's been applied to other populations, adult surgical populations, kidney transplant population. I just put this in there because I'm going to be talking about transplant, but in an adult kidney transplant population, the presence of frailty is associated with a 2-fold increase in mortality and with delayed graft function. So having heard about this concept, really the adult hepatologists are ahead of us in this, and they've really study this in great detail in the adult population. So people may be aware, but the way that we allocate livers for transplant are using the PELD or the MELD scoring system, MELD for people aged 12 and over, which are really primarily laboratory-based assessments of how you allocate an organ. So in this quite important prevalent study from 2014, an adult group from UCSF, what they did was they took 300 consecutive patients who were listed for adult liver transplantation, and using the Freed frailty criteria, found that frailty was prevalent in 17% of them. That's fine. So adult patients who are cirrhotics waiting for liver transplant are frail. But more importantly, frailty strongly predicted waitlist mortality, even if you adjust for liver disease severity. So importantly, if you look at the dark shaded bars, the way this is divided up is by frailty and by MELD score. So if you have a high MELD score, which would be your classic way from a laboratory assessment of predicting of what your mortality is going to be like, but if you're frail and you have a high MELD score, you have a 23% mortality on the waiting list. But if you have a low MELD, so the other dark bar, you have a low MELD, but you're frail, you have a similar mortality. So frailty is predicting something, or it's encompassing an aspect of morbidity or mortality that's not captured by MELD. I'm not suggesting that we replace MELD with frailty, but the two are probably synergistic because they're measuring two different things. So how are adults using these types of data? So in the adult world, what they're really thinking about is a patient too sick to be transplanted? And here it's really the concept of some disease, when you transplant people, is transplant responsive. You can fix certain aspects of liver disease by transplanting them. But some aspects of disease can't be fixed by transplant. So they use this concept of some disease being transplant unresponsive, non-responsive. If you take candidate C, a lot of their morbidity is transplant unresponsive. They're not going to get better after you transplant them, so probably you shouldn't transplant them at all. These are very adult concepts. These are the ways that the adults may think about using frailty. It's probably not what we would want to do. So how can we apply some of these concepts for children, and is it relevant? So the PELD score, which is the under 12, largely laboratory-based assessment of liver disease severity, is a fairly imperfect system for allocating organs in children. We know that more than 40% of children are allocated organs by an exception system, meaning we calculate their PELD score, we think, this PELD score doesn't really encompass how sick this child is, and so we apply for exception points to bump their score up. And almost half of our kids are being allocated organs in that way. So we know that the PELD system doesn't capture morbidity associated with end-stage liver disease, and as an aside, it's not also predictive of post-transplant outcomes. So reliable clinical and biochemical markers of liver disease severity currently are inadequate. We know that nutrition is really important. We know that nutrition is probably one of the single most modifiable determinants that we have when children are waiting for transplant and will determine post-transplant outcomes, but it's difficult to quantify in children because there are confounders such as ascites and organomegaly. So what we feel is would be ideal for liver disease, and I think other aspects of chronic disease, would be a global assessment tool that's reliable, objective, and it has mechanistic underpinnings. And that's where we felt that frailty could fill that gap. And here I just posed two pictures of the sorts of children that we may see in liver disease. The first child up here in the corner with the pink, she's clearly frail, right? That's a child that we could all easily can imagine that this child is frail. Us as pediatricians, we pride ourselves on having this gestalt about how sick a child is. We know this, right? We can go and we say, oh, that child's sick. We don't even need to look at the labs. I know that child's sick. But what about the other child down there? So that child actually has cholestatic liver disease. There's a lot of scratching. That's what the scoriations on the forehead are. Is that child frail? Harder to know. You'd have to probably examine the child. You'd have to see, is the child wasted? Is that belly looks quite full? Is that full because of ascites? Is that full because of organomegaly? Harder to know. So even though I think we know as pediatricians that we have a gestalt of who is frail or not, I would say that it's not always reliable, and it's hard to quantify. And that's the most important aspect, because we can't quantify these aspects of how frail that child is compared to that child. And also, we don't really know how to track this first child's frailty. I don't know if today that child is more frail than they were a month ago, because we don't have an objective way of measuring that. So our goal was really to adapt this adult frailty tool for children and then to determine the prevalence of frailty in children with end-stage liver disease. And our overarching goal for all of this is not like the adults. We're not going to try and say this child should be transplanted, this child should not be transplanted. What we're trying to do is optimize children prior to transplantation. So we want to prehabilitate them so we get the timing of transplant right. So we want to transplant them at the time where they're going to have the most benefit. Maybe that's earlier than we would anticipate in some children, but certainly it would give us an opportunity to intervene to optimize them before we put them through transplantation so that they have the best possible outcomes. So the ideal way to have done this probably would have been to start from completely from first principles and to derive an entirely new tool. That would have taken a decade. We didn't do that. What we decided to do was to adapt the freed frailty criteria, which had been well validated in adults, but to find pediatric tools that could measure those aspects in children. So for weakness, we used grip strength. Same reason is because there are validated norms for grip strength. For slowness, we also used the 6-minute walk distance because there are validated pediatric norms. For exhaustion, we adapted this to use the PEDS-QL multidimensional fatigue scale. Shrinkage obviously isn't a concept in children in the same way as it is with adults, but we use the tricep skin fold thickness. And for diminished physical activity, we use the questionnaire base called the Physical Activity Questionnaire, which also has pediatric norms. All of these things, these tools have norms that are applicable in children aged 5 and over. So this tool could only be applied in that population. And instead of scoring it 0 to 5, we decided, because we were using Z-scores, because all of these assessments can be measured with Z-scores, we felt that to have a little bit more nuance in our score, because we felt that children have, I think, more spectrum of disease, we would score them as you can see at the bottom, as 0, 1, or 2, depending on what your Z-score was. So that the maximum score for frailty in the pediatric population would be 10 rather than 5. This is just to show a little bit about what the tools are like. I think that we want to emphasize that this is relatively easy to do. It doesn't take fancy equipment. This is a dynamometer that you can measure grip strength. You get the children to do it 3 times. It costs about $200 on Amazon. So this is not fancy. It's not hard to do. And the 6-minute walk test is widely done for exercise tolerance. And basically, you just see how far a person can walk in 6 minutes at their own pace. So you need a flat, hard surface. That's the requirement. And this is what we did, and I'm now going to go through this study a little bit to explain this. I also like to highlight the fact that this was a multi-center study performed with no funding, and this really speaks, I think, to the collaboration between pediatricians. I want to highlight that Dr. Book and the center was, of course, part of this. I really just called all my friends, and everybody said, yes, we will do this. And it was great, and I think that this is the first, if you go to PubMed, this is the first study of frailty in children. So we're kind of excited that we were able to do this. So I'll show you what we did. We had a cohort of originally 80 children, and then after various exclusions, we had 71 children across all these centers, and they were divided into children with end-stage liver disease who were listed for transplant, and our control group was a disease control group. So these are children who had compensated chronic liver disease, the kids that you would see in clinic who are well, are at home, but have a liver disease. And if you look over at the colored panels, you'll see the sorts of diagnoses. In the listed population, they were the diseases that you would expect. Diseases like biliary atresia, Alagille syndrome, and then in the compensated group, in the disease control group, lots of patients with autoimmune hepatitis, they're well. We excluded children that were on higher doses of steroids, but that's sort of your routine ambulatory liver clinic. If you look at the frailty scores, if you remember, 10 means you're the most frail, 1 or 0 means that you're not frail. In the whole cohort as a whole, so this is all the children with liver disease together, the median frailty score was 4 in this group. And what was driving that? Many of these children had problems with grip strength and 6-minute walk distance. And I think that's important because these are performance-based metrics that probably speak to muscle function, and we'll talk about sarcopenia at the end, but that's what children in general with liver disease have problems with. We then, of course, wanted to analyze this as 2 different groups, and clearly the children with end-stage liver disease had higher frailty scores, the scores being up into the region of 6, 5, as compared to children with just compensated chronic liver disease. And what was driving those differences? What was driving those differences was actually a lot of exhaustion and fatigue is what was driving that in the children who were listed for liver transplantation. We also then wanted to see if we could see if we could really figure out what the cutoff was that could, using these scores that could determine the difference between these two groups, and found that the cutoff was 5, so that a frailty score of 5 will determine a cutoff between children who with compensated liver disease and those who were listed. And if you use the cutoff score of 5, in the entire cohort, 24% of them were frail. And most importantly, in the end-stage liver disease group, 36% of the population would be defined as frail using this cutoff score. So clearly a real problem. But what, again, it's capturing a gestalt that we all know. We know that these children are frail, but now we have a way that we can measure it and we can quantify it. And that this was only a one-time baseline assessment. More importantly, what will be interesting to see is if we can follow it and to see if there's a trajectory to frailty in children listed for transplant. We did a little bit of exploratory work as well to see whether these frailty scores had any association with MELD, sodium MELD, which is used in children aged over 12, laboratory-based assessment, again, to allocate livers. And they were independent. Frailty scores were really pretty independent of the MELD and the PELD scores in this small exploratory cohort. So again, giving us this feeling that frailty is measuring something different than lab-based tests. We also had asked the physicians at all these sites to eyeball test these kids. Again, going back to this gestalt that we have, do you think this kid is frail? That's it, just a global question. And frailty scores are independent of eyeball testing as well. So we're not quite as good as we think we are at really determining how frail they are. Incidentally, there's been a recent adult study that's also looked at eyeball testing amongst adult physicians. And maybe we think we're better than adult physicians, and maybe we are. But they've shown that even amongst adult hepatologists, there's a lot of subconscious bias. There's a lot of assessments that women are generally frail. They unconsciously are taking into account other demographic variables like socioeconomic status, gender. So I think we have to be very wary of the gestalt and certainly using that in something as important as allocating organs. So to summarize this bit so far, I hope that I've convinced you that frailty is an important biologic concept. I think these concepts of decreased reserve and vulnerability to stressors are definitely predictive of poor outcomes in adults, but I think that they are applicable to children as well. These assessments are cheap and feasible in kids. Even in the study setting, it took us about 40 minutes per child to do this testing. Okay? 40 minutes sounds a lot to the adults. 40 minutes isn't that much for us. And I think as we get better at doing it and refine it, we'll be able to do it in less time. And as I said, I'm going to emphasize the fact that it's cheap because we didn't want to develop a tool that was perfect for a quaternary center ivory tower. We wanted a tool that can be used in multiple practice settings. And according to our first study, frailty is prevalent in 36% of children with end-stage liver disease. So it captures an additional marker of ill health independent of standard laboratory-based assessments. Now, the adults have, of course, moved along with this, and I wanted to highlight this paper that came out last year, which is both the original adult work and our work used the Freed frailty criteria, which I've described, 5 domains, quite a lot of testing. They've actually now, in a multi-center approach, have actually narrowed that down and developed a liver-specific frailty index, which actually only uses grip strength, chair sits, and a test of balance. This they can do in about 5 to 6 minutes in adults. And what's really important about it is that it's performance-based. So the original Freed frailty uses quite a lot of self-report, which we may argue has subjective elements. People may know that if I answer well on this questionnaire, I can game the system, increase my frailty score, increase my allocation. So this tool is great. It's all performance-based. Much harder to game this. It has construct validity for frailty. And in just this one figure that I took from the paper, these look at predicted probabilities of death on the transplant list in adults. And again, the same concept that incorporating frailty scores improves your mortality risk prediction, improves your ability to predict death just using MELD alone. So I think this is really where we need to be headed. We used Freed frailty because it was a good research tool, but we need to think about a much more liver-focused or liver-specific tool to do this better in the future. So frailty is, the other thing I think is really exciting about this whole concept, it's not just a description of a clinical phenotype. It has very, very important mechanistic underpinnings. We've not scratched the surface of this at all in pediatrics because we're barely describing frailty. We haven't got to understanding its mechanisms. This is just a figure that shows some of the the molecular underpinnings that have been described in adults. And I think the things that I would point out for us that I think that are going to be important that we should focus on is this concept of inflammation, that frailty is probably considered an inflammatory state. And as we move forward, we're going to think about incorporating things like measurements of CRP, if that's going to be helpful. I think we have to really think about endocrine dysregulation in our population, especially with kids, the impact of pubertal hormones, and whether or not that could be playing a part. And then sarcopenia, and that's loss of muscle mass, which I'm going to talk about later, which is a key determinant of muscle function and key to the development of clinical frailty. So you can define sarcopenia as a loss of muscle mass, and many people consider it the biologic correlate of frailty. And it's typically assessed using CT, where you just measure the surface area of the psoas muscle. So it is a CT-based test, certainly in adults, and you can do this at the lumbar level. And it's been found to be very prevalent in adult cirrhotics. Up to about 70% of adult cirrhotics have some degree of sarcopenia. So this is just showing you how it's measured. So you can do it at L3-4 or L4-5. L3-4 is probably the standard, and basically a radiologist draws this red line around the psoas muscle and then quantifies what that psoas muscle, and then you can use that as an indicator of what skeletal muscle mass is in that individual. Again, the adults have already been doing this, and they've shown very clearly that sarcopenia predicts mortality post-transplant in adults, which is really important. So it's not just predictive of waitlist mortality, it's predictive of outcomes post-transplantation. In this study, they took hundreds of adults, they had CT scans, which they did as part of their evaluation, looked at the psoas muscle area, divided it into quartiles, and showed that in the smallest quartile of your psoas muscle, your 1 year post-liver transplant survival is 50% compared to 87% survival. And this is independent again, of MELD scores and other standard laboratory based. So another highly predictive tool that can help us think about how our patients are going to do. Oh, that wasn't supposed to happen, but it has happened, so that's okay. That's the MAC-PC thing. So is sarcopenia prevalent amongst pediatric patients? So it is. So this is a paper that came out last year from Indiana, where they looked at patients, about 80 patients who had end-stage liver disease, end-stage kidney disease, and patients with intestinal failure. 3 really important patient groups that we look at, and found that the patients, the panel up there just shows the liver disease patient, but basically shows that they compared them to healthy controls and showed clearly that this patient population has a smaller surface muscle area, and so has sarcopenia. Interestingly, when they looked at the study groups between the controls and the disease groups, there's no difference in BMI. So BMI is not a going to replace it. We're measuring something different here. And what was really interesting, when they looked at the psoas muscle, a lot of the muscle in these kids is replaced by fat. In fact, in the intestinal failure patient, they had 250% more fat than the controls, leading to this concept of sarcopenic obesity, that what's happening with our patient, even though we think we're introducing nutritional rehabilitation, we think we're doing a good job, we're replacing muscle with fat. This is not going to help our patients, and so sarcopenic obesity is an important thing for us to keep in mind as we think about how we're going to design interventions to address this. We've looked at this in our population as well. We looked at 23 children, at sick kids who were listed for transplant. We do a lot of live donor transplantation at sick kids, and so many of them get CTs. So these were clinically indicated abdominal CTs, and we compared them to 46 controls from a trauma database. How else do you find controls? And found that at both of the lumbar levels, L3-4 and L4-5, kids with end-stage liver disease listed for transplant clearly had worse psoas muscle surface area, clearly had more sarcopenia than the healthy controls. The other important thing about this paper is that more than 60% of the kids in this study were under the age of 1. So the frailty testing that I showed you at the beginning, which obviously is an exciting tool, is only really applicable in kids over 5. Those are performance-based metrics. You can't get a 6-month-old to do any of those things. So we have to think about our population differently, and I think sarcopenia is going to be the way to go for our younger population, and that's why this is important, because this may be the way that we can assess sarcopenia and therefore get an assessment of frailty in infants. So 2 studies that show that frailty exists in children with end-stage liver disease. What about outcomes? Just one study that we've seen that shows that kids that have sarcopenia after liver transplantation have worse outcomes with poorer growth, as you'd expect, but also recurrent hospital admission. So these are just early data that are emerging, but it's something that I think we should focus on. But there are challenges to assessing sarcopenia in children, which we have to bear in mind. So first of all, there currently are no normative reference data. So we used healthy controls from a pediatric trauma database, but there's no thousands of patients have been put into reference data, but we're working on this, and we've hopefully got a study coming out soon. We're hoping that we'll be publishing soon an online reference calculator where you will have that. We've got about 1,000 patients in our trauma database, and we've analyzed them all now, and they're all trauma patients. And so I'm hoping, and we've excluded patients with spinal defects or spinal injuries, and hopefully we will soon have reference data, but they're not currently available. The other problem is the methodology. So we've actually shown that MRI, you can measure psoas muscle surface area equally well in using MRI, but that's not going to be helpful for us because we don't want to sedate our patients. And CT, of course, has a radiation problem. So are there other ways that we can look at muscle mass, especially in our younger population? So one new tool that people are really thinking about is ultrasound. It's been used in a handful of studies, and it's something that we're exploring right now. And the idea would be that you'd have a portable ultrasound machine. Again, doesn't cost very much, going back to this issue of having something that's cheap, portable, feasible, and that you can just go and pop this on the thigh of an infant, get an idea of muscle mass, and then more importantly, that's also something that you can repeat over time. So that's something that we're actively exploring. There are also other non-invasive ways of thinking about skeletal muscle mass, such as urinary creatinine excretion. Of course, 24-hour urine collections are not going to be feasible again in children, but we're looking into whether spot urine collections could be helpful to look at muscle mass. And functional assessments, again, of course, ideal for older children, but not going to be helpful in the younger population. So how can we pull this all together? So this is just a figure, I think, that pulls everything together as to how we think about frailty and sarcopenia. Sarcopenia, nutritional problems, all leading to poor muscle function and poor muscle quality, leading to functional deterioration. We know what happens when people have malnutrition and have sarcopenia. They're not active. When they're not active, all of these things worsen, functional deterioration, which leads to frailty, and then an increase in adverse outcomes. And this starts with cirrhosis and end-stage liver disease, but I would suggest that you could put end-stage kidney disease up there, you could put cystic fibrosis up there, you could put a number of diseases. So I think the applicability to all of our diseases is very clear. So just to put it there, I would say that I think the frailty and its biologic correlate, sarcopenia, is very measurable. It encompasses ill health that we don't measure by standard laboratory assessments, and that these concepts are very relevant and measurable in liver disease. But there's really a lot to do next. I think we're really, really right at the beginning of what we need to do. So some of the things that we're planning, and we will be pulling in our friends here, is that really, even though we've described frailty in older children, does it predict post-transplant outcomes? That's the first thing we need to do. We're doing that right now. We need to know that measuring it has a purpose, that it actually predicts adverse outcomes so that there's a rationale for wanting to do something about it. In our older children, as I mentioned, I think we need to refine the assessment of frailty and develop a liver-specific frailty toolbox. I think although 40 minutes is feasible, it's still very much a research tool. I think we can do this with probably something down to 2 or 3 metrics, probably not questionnaire-based, probably not self-report, but like the adults have done, something very quick. Walk 6-minute walks, do 10 chair sets, and a test of balance. If we could do something similar, or with grip strength as well, if we can do something very similar for kids, it would be something very nice that we could do, and repeatedly is key. Hopefully, we will find that thigh ultrasound is feasible as an alternative way to assess sarcopenia in infants, and that's something that we're aiming for. And then all of this boils down to, if this is all true, and if this really is important, which I believe it is, how can we intervene? Because as I said, we don't want to use the concept of frailty and sarcopenia to delist children. We don't want to take the transplant away from these children. We want to optimize them so that we can get them to transplant in the best possible way. So when we've talked about this before, people just say to me, oh, but Binita, really, it's all just nutrition and exercise, isn't it? That's all you need to do. And we think we know this in pediatrics, but I'm going to say that actually it's not just about nutrition, physical exercise, even though those are very, very important concepts. There have been several studies using randomized clinical control trials of specific exercise interventions in adult patients that actually haven't had great results. So it's more than nutrition and physical exercise. I think the adults get excited about nutrition and physical exercise because they don't address those concepts on a daily basis. We already do. One of the things that they're doing in adult medicine is that they're suggesting that adults who are listed for transplant and are frail have a late, what do they call it? They call it a nighttime snack. That they have a carbohydrate snack at night, which is supposed to help them. And I think that's sort of quite funny because we tell our children to eat all the time anyway, but that seems to be a novel concept in adult medicine. But anyway, be that as it may, I think the really important thing to understand is that where, again, I think the adults are ahead of us is that they're really doing excellent biology to understand the mechanistic underpinnings of sarcopenia and frailty. And that's what we need to do if we're going to design specific therapies. So some of the things that they're doing is looking at the histopathology of muscle and looking at the contractility of muscle and trying to understand what is it about that makes muscle misbehave, as it were, in the milieu of end-stage liver disease. Ammonia seems to be a really key factor of this in mediating the liver-muscle axis, and it seems to have a direct effect on myostatin, which is reducing muscle mass. So I think I'm quite keen that we think about specific strategies such as myostatin antagonists or methods that we can really look at ammonia and maybe lower the ammonia in our patient population who are frail. Thinking about hormone replacement as well, the role of growth hormone, particularly in our population, and endotoxin. Many of our patients are chronically or at least subclinically septic, or they have subclinical bacterial infection, particularly those children with cholangitis, and that clearly is also having an adverse effect on muscle mass. So it's not just a story about feeding and growing. I think that once we get these clinical concepts clearer and we have the better tools to measure them, in parallel, we need to also be thinking about the biology. And we're certainly going to be starting to bank muscle biopsies on our children who, as they go through transplant, so that we can actually start thinking about these biologic underpinnings as well, because that's really the way that we'll be able to address this in a much more scientific way. So finally, I will just acknowledge the team that works on this with me. Dr. Vicky Ng, she's a medical director of our transplant program, really my co-PI for a lot of this work and helps drive it. Claudia Kwame, who's our research manager, and Evie Lurch, who's the first author on several of these papers, who's now sadly gone back to Munich, but try and pull him back. And thank you for your attention.
Any questions?
Thank you, Binita. That was a great talk for someone that does, both adult and pediatrics, although right now probably 70% of my work is here. I can tell you that Frailty is really, like you said, a tool that is changing everything. In fact, there's new formulas where we may not be using milk by itself, but adding this. And I think this is the perfect example of when you join us in rounds today of the 2 kids we have from transplant from this week, because we have one that had been chronically sick with 2 or 3 weeks in the ICU, in the hospital, and someone that came from home and got a living donor. And I think as I'm thinking about these children, what I start to think is what happens afterwards. What's going to be their development, or what's going to be their quality of life? I know that I don't say quality of life, Vicky would get angry. But so are there any studies now looking at the same scores post-transplant? And when would be the right time? Would you wait 2 years to then reassess these children if you want to compare, how you improve their frailty and all that, which we think we improve with transplant? And then the other question is, there a change between the age of the patients? Is if you do the biggest problem we always have is when to transplant the children, right? Because we don't have a good assessment. So if you transplant them earlier and at a younger age, will they improve their scores?
No, those are great points. And so we are actually looking at the post-transplant group right now and measuring frailty and seeing whether the pre-transplant frailty predicts post-transplant frailty, but also is associated with other post-transplant outcomes like days in hospital, days in the ICU, days on the ventilator. So we're looking at that at the moment. The issue of when to transplant, I think, is the most crucial thing that we have. I think take a patient with primary sclerosing cholangitis, right? So she's 15. One day she's playing varsity football, okay, varsity soccer, and football to me, soccer, just wanted to break that. She could be playing football. But anyway, she's playing a varsity sport, and then in the space of a year, her liver disease progresses, and then when she comes to transplant, she comes in on a wheelchair. So my question is, in that year, we probably failed to intervene early. We've all had patients like this. We failed to transplant her earlier. And part of the reason is that her labs probably didn't change month 1, month 2, month 3, month 4, month 5. And so they didn't change until the very end. But I would argue that she was probably getting frail earlier on. The other important thing about frailty is that frailty is modifiable. in a way that your labs are not. If your bilirubin and your INR are deteriorating, those are non-modifiable factors, whereas frailty is much more likely to be a modifiable risk factor. So, and I think it's actually quite empowering for families as well. It's really hard for families to tell them that their MELD or PELD is this, and that's where they are, and there's not much they can do about it. But it's actually a motivator, especially in adolescents and, who I think can get their heads around this. It's a motivating factor for families that you can modify your frailty. And that's why having a tool that we can repeat is really important, because I would say that's a message that I would like to give to my families, is that this is your bilirubin. I can't change it. But this is your frailty. We can change this. This is what we're going to do, X, Y, and Z. And then when you come back, we're going to keep checking it. So I like this idea of a modifiable issue as well. And then that will address the issue of timing. And I think we will end up transplanting some of these patients earlier than we previously did. And then if we incorporate frailty into pediatric allocation systems, as they're starting to do with adults, then it'll be better. And we hopefully then won't need this sort of ridiculous exception system, which we currently have, every other child is getting, we're asking for exception system scores. Points, because the system doesn't work. In fact, in Canada, we think the PELD system is so inadequate. If your average patient with biliary if you calculate their PELD score maybe, I don't know, single digits, fair? 5, 7. We allocate all children in Canada from the get-go with the PELD score of 24. That's what we do. Because we don't think PELD really, the calculated PELD doesn't help them at all. So.
I was going to ask that same question, but I'm going to take that a little bit further. I'm in pediatric rehab medicine, and we take care of kids with chronic conditions all the time. Some of the kids have conditions that will never get better, so we know that they're going to continue to decline. But in your population, you're talking about something that gives us an opportunity to change it. Historically, we've always thought about deconditioning, this idea of you're out of shape, and therefore you should just go to the gym and get going. And we haven't been able to get any traction with payers to recognize the value of strengthening programs and even an inpatient rehab stay post-transplant or during this course of stay, maybe pre-transplant, to see if we can modify your risk factors both before and after. So thank you for raising a really important question and bringing us to what might be the next step. We might be missing things.
That's great. And that we're absolutely going to have to work with rehab medicine, such a crucial part of this. But the key is I think with interesting, you make the point about payers. I think payers want metrics, hard metrics, and they want to see associations of that metric. So this is why this is important. We're trying to get funding now to refine the metric in kids, but that's the key. If I can say this measures X, and when I measure this, I can predict this, and that's bad, then payers are going to sit up and notice. And then that the cost, really, not that I really care about cost, but we all have to care about cost. But if we can say that the outcomes of transplant are going to be better, and that we're not going to waste organs, or if you want to use it in that awful term, I don't like that term, maybe that will be the way that we can convince people to pay for these prehab. And I like that concept of prehab. I think it's really important. So we'll need you.
Thanks for introducing a concept that I was very unfamiliar with, except my personal experience of becoming more frail as I age. Your world is consumed by rare conditions. I'm a general pediatrician, or I was a general pediatrician. Most pediatricians don't worry very much about whether somebody's going to survive a liver transplant or not. But this concept may be of importance in a broad variety of conditions. So I wondered if you could speculate a little bit about, I was struck by the sarcopenic obesity, normal BMI, presumably. So if you were measuring muscle mass in people who were otherwise healthy looking, would that be of use to make them more fit or more healthy or improve their survival or quality of life or whatever?
I think absolutely. I mean, I think about the cystic fibrosis population. I think many of them are sarcopenic. I think the metabolic disease population, I think we make them fat, frankly. We see this. We partly because a lot of them need low protein diets. I understand that, but we're making, I bet they have sarcopenic obesity. So I think I can easily pick, I think in disease populations that I think everybody who goes to clinic today will look and be able to find in their non-liver disease population. I think some of our inflammatory bowel disease patients are probably also frail. I think that I would like to say to people, like, go out there and please measure frailty. That's really, if I have one message, it would be that. I mean, we'll take care of the liver disease kids, but I think that there are so many aspects where we could use this. And there are very little. There's one study of sarcopenia or a couple of studies of sarcopenia in the oncology population. That's an obvious population to look at as well. Chronic disease where we want to optimize outcomes. So I would say, like, please go forth and measure it, and let's see what we find, and then we'll learn more, right? And we'll probably have to attune the metric for some, for different disease populations. And maybe cystic fibrosis, we'll have to look more at cardiopulmonary aspects of that, which we haven't really addressed that much in the liver tool. But we can modify this, but it's just that we shouldn't be, this should be a known concept amongst our field, I think.
I just want to highlight that was a really exciting talk. One thing I want to mention, I think you might find really exciting, because you talked about the difficulties of looking at sarcopenia or measuring muscle mass in children. Dr. Bill Evans from UC Berkeley, who's kind of a pioneer in defining sarcopenia and measuring that in older adults, has recently developed a technique where you use labeled creatine to ingest, and you can do a spot urine sample the next day, fasted, just one sample. Very inexpensive, less than $50, and he's validated this in older adults. And I believe I've been in contact with him lately, and he also has a paper using this in children, looking at tracking this in neonates, in infants, and children. It seems like a really exciting tool that can really access a lot of these populations that you can access with and have a better assessment. This method is more precise than MRI, more precise than DEXA. And recently we've received funding to develop it at the University of Utah. So it seems like a really interesting and applicable technique that could be used in the future.
No, that's brilliant. Thank you so much for mentioning that. And you're absolutely right. I just had a PhD student start in September, and that's going to be her project, actually, is to do that. I didn't discuss it because I didn't have any data on it, but yes, I think you're 100% right. For the younger population, CT is going to be tough, maybe the thigh ultrasound, but we're going to do a study where we're going to validate CT, thigh ultrasound, and the creatinine test that you said. I think it's really important, so thank you for mentioning it.
Do you think this issue could be impacting all the children that are spending so much time on the computer and their iPhones instead of out and about? Are we creating this kind of obesity?
And that's a fantastic question. I mean, we're certainly creating obesity. I mean, I would say probably. I mean, I would say absolutely. And do you mean I'm going to say so-called healthy children? Yes. I think that's a brilliant concept. I've really thought a lot about our disease population, but in a sense, I think they're a disease population as well. So, yeah, I think that's a great idea. We should probably be looking at that in our patients with fatty liver disease or metabolic syndrome. Yeah.
So I'm interested in how this would apply to palliative care. And in patients, I'm wondering if you looked at, in addition to improved post-operative outcomes for children who had better frailty scores, if there was any improvement in quality of life for kids that had better frailty scores or kids that go from having a high frailty score to a low frailty score.
Yeah, we haven't done that yet, but the multidimensional fatigue scale is included in the frailty test. So two issues with that, which I think are really important. So the study that we're designing right now, which is going to be a multi-center study, which looks at long-term outcomes, a key component of the composite endpoint is going to be quality of life. It's really hard to find. There is no one, because if frailty is our variable that we're measuring, we need an endpoint. So the endpoint, one of the key components of endpoint is going to be quality of life. The question is what quality of life tool to use. So we have generic score with PedsQL, which has some value, but there are issues. There is actually, Vicky actually has developed a pediatric transplant-specific quality of life tool, so we may well use that, but we're working around that. So I think your question is exactly the right one, and it always goes back to the same question about how do you measure this properly? If you measure it and you don't find the answers that you were expecting, is it because they're not there or because you didn't measure it properly? So tools, I think, are the most important thing. But yes, I think you're absolutely right. Quality of life is going to be, it's going to be like 50% of my composite endpoint is going to be quality of life. I'm just trying to figure out the best tool to measure it.
Was there a hand? Sorry.
Hi, Binita. Welcome.
Hi, Marion.
So a question about specific to liver transplant, sorry, but many of our patients who undergo liver transplant are less than 1 year of age. What are the thoughts in the community about addressing that very frail population, especially those biliary atresia patients?
All right, so my personal opinion on is with biliary atresia. I'm going to start with nutrition because that's the easiest thing to do. We know in biliary atresia that kids with a good outcome, as in good outcome defined as native liver at 24 months, and kids with a bad outcome, which means transplanted by 24 months, somewhere in that period, all kids with biliary atresia have malnutrition. So we are not addressing nutrition properly in biliary atresia, period. Good or bad outcome, they all have malnutrition. Kids with a good outcome don't achieve normal anthropometrics until 1 year post-Kasai. That's appalling. In the hands of liver specialists, they don't achieve their growth potential. So having said that, I think that what we need to do is top-down approach to nutritional therapy. I think the IBD team have got this right. They do top-down approach for IBD. For some reason, in liver disease, we play catch-up. I think that's wrong. So my mission is that I think that every kid post-Kasai should go home with an NG tube. And I think that they should then prove to us that they can take feeds orally, and then we can remove the NG tubes. That's top-down nutritional approach, and that we should be more aggressive about using TPN. I think it's really important, because otherwise what we do is the typical sequence is we see these kids in clinic, the kids don't grow, we fortify the feeds. They come back a month later, we fortify the feeds again. They come back the next time, we tell them about an NG tube. Mum cries, dad gets angry. Bring them back the next time. It's the same sequence, meaning we catch up to the concept of supplemental nutrition in biliary atresia, and we can have 3 months of suboptimal nutrition, whereas actually it's ridiculous. They should just go home from Kasai with an NG tube in, and then they can prove to me that they can feed, and I'll take it out. So that's what I think. So that's what I think we should be doing for the kids under 1. We'll do a much better job of that.
Okay. Lovely talk. How about UNOS and their, I thought that was a big thing in the room, but UNOS in terms of your research and changing MELD and PELD allocation?
Yeah, but I think the adults are already on it. So I think once I think Manuel already mentioned it, the adults are already UNOS is already they're already paying attention to the fact that frailty plus sodium MELD is going to be a better predictor. I think it's only a matter of time now. So once the adults have it, but then we have to be ready in pediatrics with a good tool. Manuel probably has a comment, yes.
I think for children, because just what Binita said, that we know PELD is not a great system. And what you said, and I think a lot of the members of the audience don't know, but the PELD score that we used to that we are using to see how high a patient goes on the list, like Binita said, 40 to 50% of the children are not using it. We're writing exceptions. And it turns out that is whoever writes the better letter gets better points, and then, because we have a national review board. So Dr. Book and I, and actually that's how we met originally, there's right now a task force within the US, which has, centers from, I think at least, members from at least 14 centers, and Vicky actually has been an advisor on it too, that were basically trying to get rid of PELD. There actually was a PELD subcommittee within UNOS that, we've been discussing this for 10 years, but these are what everybody's looking for, new ideas that we can, the only reason why we have not been able to get rid of PELD is because there's not a better score, right? Because we know we're not using it. So I don't think PELD is going to go away completely because it's an objective, but I think it's going to be, just like you said, PELD plus frailty and nutrition, or like other things, maybe adjust like the adults have adjusted their MELD by adding the sodium. I don't know what is going to be the next.
That's exactly right.
But there is a group that is trying to change it, but unfortunately, there's so much politics because most of the patients waiting for transplant are adults, and so we've been fighting, just like the Canadians and the Europeans have to have our children, have more access to transplant, so there's no waitlist mortality. But obviously, when they look at percentage, it's the adults that are, have more patients dying, and so it's. What do you think, Dr. Book? Another 2-3 years, but hopefully we'll get there soon.
It will change. Yeah, exactly.
Any other questions? No? All right. Well, happy holidays. Be safe. Enjoy your families. We'll see you January 3rd.
I always leave him.